Good morning, everyone. Welcome to this conference for the Ovarian Cancer Research Alliance's national conference here, Uniting for Hope. I think that that's sort of the theme for the conference, and we're thrilled to be here with you at this annual Ask the Experts session, as I am humbly asked to chair this. My name is Beth Karlan. I'm a gynecologic oncologist. I have the Nancy Marks Endowed Chair in Women's Health Research, and I'm professor and vice chair in the Department of Obstetrics and Gynecology at UCLA. I'm also joined today by my friends and esteemed colleagues, Dr. Andrew Berchuck, who is the James Ingram Distinguished Professor of Gynecologic Oncology and the Chief of the Division of Gynecologic Oncology at Duke University, where he directs the Duke Cancer Institute's GYN Cancer Disease Group. Dr. Kunle Odunsi, who is the AbbVie Foundation Distinguished Service Professor of Obstetrics and Gynecology and a Professor of Medicine. He directs the Comprehensive Cancer Center at the University of Chicago, and he's also the Dean for Oncology in the Biologic Sciences Division. And my friend and colleague, Dr. Premal Thaker, who is a Professor of Obstetrics and Gynecology, Director of the Gynecologic Oncology Clinical Research Unit in the division at the Washington University School of Medicine. We are all participants on OCRA's Scientific Council and really thrilled to be here with you. Ovarian cancer it's a very exciting time. There are many advances. The meeting this year is sponsored by over 20 pharma partners. And I think that just speaks to all the investment that we have in advancing ovarian cancer. All of us are dedicated to allowing you to live your best life despite having ovarian cancer. Over 100 questions were sent in, and I'll do my best to have us address them, some that were asked most frequently, and grouping them. During this session, we're going to focus on various treatments, maintenance therapies, and ways that these new advances have allowed us to live longest. So we'll go and ahead and get started. Perhaps Dr. Berchuck, I can start with you. So many of the questions focused on how do we approach women with recurrent ovarian cancer, whether they're recurring early, recurring late, and sort of a general paradigm for how do you approach a patient or how do you counsel a patient with regards to her risks for recurrent ovarian cancer?
Well, that's a lot, but I can start off by saying, I can kick it off by saying that we're very fortunate right now to be in what I consider a renaissance in ovarian cancer therapy. You know, for so many years, I remember going to our national cooperative group meetings, the GOG, and it just seemed like we were stuck on cytotoxic chemotherapy. So it was topotecan and son of topotecan and nephew of topotecan. And I really had very little faith and confidence and enthusiasm that was going to really take us forward, because it seemed like we'd really hit a wall where there's only so many cytotoxic drugs you can put together and give at the same time because of the toxicity that patients can have when they're taking more than 2 or at most 3 of those drugs. But fortunately, in the last 5 to 10 years, again, there's just been this renaissance driven by our understanding of the underlying biology and molecular genetics of ovarian cancer, where we now have PARP inhibitors and immunotherapies and ADCs, antibody drug conjugates, and anti-angiogenic therapies. And so really there's just a flurry of excitement and trials and companies that are involved, and we're seeing FDA approvals and advances. So I feel like as a gynecologic oncologist, I have many more arrows in the quiver, so to speak, when it comes to offering treatments that keep patients going month after month, year after year, and also with a manageable sort of side effect profile where quality of life can be good. So
fantastic.
I'll defer to some of the other panelists to maybe fill in some of the blanks.
Premal, why don't I focus us a little bit more then? Let's say you have a woman who you've been caring for, and she recurs at 5 years after her initial diagnosis. How do you approach that patient with regards to surgery versus other treatments versus the role of HIPEC, if you can also comment on that.
Sure. So I agree. I think, when you reach 5 years, that's great. Obviously, it's a little disappointing to the patient because they thought that they were cured, right? But, we sort of look at them again saying maybe they really are a surgical candidate because of the fact that they had such a good response, and looking to see if their performance status is good so they don't have comorbidities or other health issues that we worry about might make it harder. And talking about the patient of really doing that sort of secondary debulking, for that patient, and then giving them chemotherapy. If we think that it's too advanced, then maybe we would want to give neoadjuvant chemotherapy. And I know we have really good data for at least looking at neoadjuvant and then HIPEC at the time of interval cytoreduction, showing that that's beneficial, followed by chemotherapy. But we still want to study that. There's some exciting clinical trials coming about looking at that question, because the data we do have to date from at least our colleagues in Norway took a long time to obtain. And so I think there's some question as to the best timing of when to give HIPEC. What is the benefit?
Want to just go through what HIPEC is? Not everybody in the audience may know it.
Sure. Yeah, that's a great point. So hyperthermic intraperitoneal chemotherapy to be given. So it's actually in the operating room, given with catheters, and a lot of times it's medications that chemotherapies patients have seen, like cisplatin, so a platinum agent that's given for about an hour or so. And then afterwards, the patient is closed up and will recover from surgery. And then after recovery, go on to get additional chemotherapy. So I think a lot of us are trying to look when is the best timing to give HIPEC, this type of chemotherapy. What is its role? Because I think we're still learning. And I think the most important advancement, to just say like how we're advancing, is just our molecular characterization, right, of ovarian cancer. It's not just looking under a microscope and saying it looks like high-grade serous anymore. So I think that's what's letting us make these breakthroughs, right, for therapies of ADCs, immunotherapy as well.
Yeah, I think echoing Dr. Berchuck's points with regards to really bringing ovarian cancer into this new renaissance, where it's not one size fits all, even based on histologic subtypes, but now we can actually get into some molecular subtypes. So what is the benefit of HIPEC? If I can just stay on that for a second. I mean, how much survival benefit, and what's the biology underlying its use?
Yeah, so the progression-free survival benefit, at least from this larger, phase 3 clinical trial, was about 3.5 months. And the overall survival benefit in those patients was about a year. So, there definitely was an overall survival benefit, which I think has made all of us sort of interested to know, how do we gain that benefit and what is the timing of it? So as I said, I think there's definitely been some trials that have not shown that same benefit, especially in the recurrent setting necessarily. But I think the patient that you proposed is 5 years. So it's almost like a new diagnosis in a sense. So in my mind, I think that patient may have more of a role than, somebody who recurs a year later, and to offer them HIPEC, unless they're on a clinical trial.
How do you select someone for a secondary cytoreductive surgery?
So, I think it's interesting because I feel like, having done my training, it seemed that we did more of the secondary cytoreductive surgeries, and probably because of the fact we didn't have such this armamentarium of better medications. So we always thought a scalpel would be helpful. But I'd say, patients who have more of an isolated recurrence, looking at timing of, as I said, when they finished and completed the prior chemotherapy, as well as what is their sort of comorbidities, because some of our patients do unfortunately suffer side effects from their upfront therapies, as well as, we've had traditionally said a CA-125 less than 500, not a lot of ascites. But, I think we personalize it to the patients. But I will say there's less of a role, at least in my practice. I would be interested to hear if Dr. Berchuck or Dr. Odunsi feel differently, that they are seeing a rise or
I think we have 3 clinical trials showing that for patients with the right selection and using those selection criteria, secondary cytoreduction can, in those instances, actually have that improvement in survival, as you spoke of. you know, many patients, even with late recurrences, as you know, have multifocal carcinomatous type of disease, and our imaging, CA125 ascites, and the factors you mentioned are very helpful. But those with oligometastatic, or just, 3 separate areas where we think we can achieve, R0, again, optimal cytoreduction, no visible disease, I think that those women, but if you're not in that group, I think it gets back to what we've all been saying about the excitement around all the really effective treatments like we've never ever had before. And one other word on HIPEC, because there were a bunch of questions about it. I think, again, it's timing, it's individualization, and the idea is that acutely after the surgery, and with the heated chemotherapy, the chemotherapy that has that dwell right against the tumor will be more effective and will have that longer term advance. So we'll see how that goes, but I think that there are some good data coming out. And I know in my practice, you've been able to get it reimbursed by insurers, so that should not be a large obstacle. Kunle, Dr. Odunsi, maybe you can talk a little bit about both the tumor biology, how it changes with recurrence versus early, and how that might influence the patient's course and the treatments that we approach.
Yeah, so that's a good question. One of the things that happens with ovarian cancer treatment sometimes is the fact that the tumor evolves something that we call adaptive resistance to therapy. So essentially, it's almost like the tumor gets used to the chemotherapy, for example, and then begins to adapt so that the chemotherapy is no longer effective. So that's one thing that can happen in ovarian cancer and in many other types of cancers. There is, of course, also something called intrinsic resistance, whereby the tumor is primarily resistant to chemotherapy. This is why we have patients who, a subpopulation of ovarian cancer patients who don't respond initially or relapse very quickly. That is the category that we generally call platinum resistant. And then the category that Dr. Thaker described earlier, where you have 5 years gap, essentially more than 6 months, 12 months gap, that is the category of platinum sensitive. Those patients are more likely to respond to re-challenge with chemotherapy, especially platinum-based therapy. But for patients who have ultimately develop resistance, either intrinsic resistance or adaptive resistance, and become platinum resistant, it's very clear that there are changes in the tumor biology. First of all, many of these patients harbor the tumor environment. If you actually look in the tumor, is hostile to the immune system, because the immune system is supposed to eliminate tumors. Studies by our group and others have shown that when you have large numbers of immune cells, T cells in ovarian tumors, those patients tend to do better. So if you now have a situation where you have the tumor has adapted by suppressing the immune system within the tumor, then trying to resuscitate the immune system might be much more difficult. So those patients are more unlikely to respond to immunotherapies, more unlikely to respond to different types of therapies. So going back to one of the earlier points, it's very important to characterize the molecular nature of the tumor, either by obtaining a biopsy or nowadays also potentially by looking at circulating tumor DNA. So we have made a tremendous advance in understanding what is going on with the tumor site, and therefore we can make more precise, targeted therapies for each individual patient.
Yeah, and I think that great points again, and the idea of each individual patient having slightly different characteristics, perhaps their ovarian cancer and their immune system. The tumor and the host interacting in very, very different ways. We'll get to some specific trials, but I think, Dr. Berchuck, you mentioned in the platinum-resistant group, because often that's where everyone ultimately ends up, it seems. Can you talk about some of the new antibody-drug conjugates and how that has, again, revolutionized our approach, and how they work in general, and perhaps mention mirvetuximab as it's FDA approved for ovarian cancer?
Sure. So the antibody drug conjugate involves taking an antibody to a protein or antigen that's present on ovarian cancer cells, and so that antibody can bring the reagent to the cancer cell, and then linked to that antibody is some sort of a cellular toxin that a lot of them involve disrupting microtubules, which are important in cell division. So, again, it's sort of like a heat-seeking missile. Folate receptor is the target for mirvetuximab, the first ADC to be approved, and folate receptor is highly expressed by many ovarian cancers, and so mirvetuximab can be delivered, to those cancers where the antibody takes it right to those cells. Now, it's not 100% expression on the cancer cells and 0% expression on other cells in the body. So, there can be some folate receptor expression on other cell types. And with mirvetuximab, the main sort of novel side effect or adverse event is keratitis or ophthalmologic toxicity. So all the patients who are being treated by mirvetuximab have to be seen by an ophthalmologist and have an eye exam before every treatment. And they have, they have eye drops that they have to take prophylactically to try to prevent inflammation and problems in the eyes. Fortunately, that hasn't turned out to be as much of a problem as I thought it would be. We managed to find an ophthalmologist who was enthusiastic to work with us, and he sees those patients. And I've only had maybe 1 out of a dozen patients who's had to have a dose reduction based on the ocular toxicity. So it's been tolerated pretty well. And
I think it's becoming. Go ahead.
I was just going to say the response rates in the trials that led to FDA approval were about 40%, which is more than double what you'd get with typical chemotherapies like gemcitabine or Doxil in a platinum-resistant setting. So it does seem like a major advance. Now, 40% response means 60% not, but some of those patients also have disease stabilization. And so clearly this treatment is benefiting many of our patients to a degree beyond the sort of drugs that we had before that we were using. So there's been a lot of enthusiasm there. And, the mirvetuximab is only given to patients whose cancers have over 75% of the cells with folate expression. And there's some other agents that are targeting folate receptor that are also ADCs that are being developed for the 25 to 75% range. So hopefully we'll have some other choices in that category as well in the near future. But
so
it's definitely been the best thing to happen in platinum-resistant ovarian cancer in the last several years.
Yeah, I think this idea of antibody-drug conjugates, the smart bombs, targeting the cells as a selective nature, and then inserting, when the cell dies, having a halo effect of killing other cells nearby, really hopefully will replace chemotherapy, which indiscriminately kills cells that are rapidly dividing. And antibody-drug conjugates, the first one FDA approved in ovarian cancer is mirvetuximab, but clearly in cervical cancer, we have antibody-drug conjugates in breast cancer and many other cancers. So I think this is an approach moving forward. And even looking at it now in the platinum-sensitive group, right? So we have trials in platinum resistance with antibody-drug conjugates, mirvetuximab ongoing, other folate receptor targets, but the Destiny clinical trial was looking at HER2 antibody-drug conjugates. And there are others looking now at Claudin-6 as an antibody drug conjugate. So really getting back to what you were saying earlier, all of us have been saying about the biology and all the investment of our tax dollars to give us grants to understand biology is finally translating from our laboratory benches to our patients and really allowing them to live longer. I too have been very excited to see the responses, to really see tumors melt away by treatment with the mirvetuximab. I've seen a little bit more ocular toxicity, perhaps, and patient, maybe it's all our bright sunshine here in Southern California, but with some treatment delays and working with our ophthalmologists and dose reductions, I'm not sure I've had anyone have to come off the drug if it's working based on that. And I think the longest patient I have has been on Mirv for over 2 years.
Oh,
So
wow.
it really can lead to stabilization. From the trials that we've had continuing to have ongoing.
Can
Is
I
anyone-
just add one thing, Dr. Karlan, not to
Of
interrupt?
course, please.
I think also what's interesting is, trying to look at some of these drugs potentially, as you said, they're moving also earlier in lines like
Yes.
platinum sensitive, but also looking to see, could they also help with maintenance, right? There's some thought to using them as a maintenance drug maybe as well. So, I think it's exciting that we can also mix up these drugs for different sort of times of a patient's journey as well.
Well, and the new ADCs that Beth mentioned that are targeting other targets other than folate receptor, I would foresee potentially the possibility that it's not like you can just get one ADC, but you could move from a folate receptor targeted ADC to, ADCs that target other antibodies. And there's no reason they should be resistant.
Right.
Exactly. I think, as I say, this is an exciting time for clinical trials. And I would just, there is another session, I think they're calling it Clinical Trials 101, that Shannon Weston is giving to the attendees at the meeting. I would tell you to, try to tune in and hear that because there's so many exciting trials. Katie Moore is also has an on-demand session on experimental therapies for ovarian cancer. So hopefully you can get some more information there as well. But I would encourage everybody to find out, discuss it with your physician. Clinical trials are they're not a last resort when you've used up everything else. This has really been exciting. And so many trials have shown that individuals with cancer who participate in clinical trials actually live longer. So don't be afraid. And when you do get second opinions. Dr. Odunsi, we're talking about some clinical trials with ADCs, but I know you've had a really lifelong passion to better understand immunotherapy in this area. And there's so many really great immunotherapy trials right now for ovarian cancer. Would you share some of that information with us as well?
Yes. So as we know, immunotherapy, the use of immune checkpoint inhibitors, especially PD-1 inhibitors, have not been very effective in ovarian cancers for several reasons. Some of the reasons include just the very hostile environment, the immune environment in ovarian cancers, where the immune cells, especially the cells that are supposed to recognize and destroy cancer cells, those cells are essentially incapacitated. And so so many trials are ongoing, trying to see how can we rescue those cells more effectively by testing different combinations. So there are several ongoing clinical trials testing combinations of immune checkpoint inhibitors with various strategies. Some have been published, some are not published yet. Some of the interesting ones that show potential signals in terms of the ones that have been published include the trial of trying to combine PARP inhibition with a drug like Avastin along with immunotherapy. There was a study called the Topazio trial from the Brigham that gave a hint of very high response rates, but this has not been confirmed yet. There was also a study that combined low-dose oral cyclophosphamide, Cytoxan, with bevacizumab, along with pembrolizumab, anti-PD-1, that also showed very strong signal of efficacy. It was a single-arm phase 2 trial, but again, those results will need to be confirmed in larger phase 3 trials. So the question is, how do we overcome the immune resistance of ovarian tumors? So there are ongoing studies now designed specifically to try and reprogram the ovarian microenvironment to make it hot, so that immune checkpoint inhibitors can be much more effective. So there are ongoing studies, for example, testing direct intraperitoneal delivery of oncolytic viruses into the tumor environment. Oncolytic viruses are very unique. They selectively destroy tumor cells, they spare normal cells, and in the process, they engender an immune reaction. Okay, they provide a danger signal to the immune system, and they engender an immune reaction within the tumor environment that is then amplified when you now give an immune checkpoint inhibitor. So there are there are preclinical studies that have shown that very well. Now there are clinical trials testing those types of approaches. The last type of clinical trial that I will touch on are the trials on adoptive T-cell immunotherapy. Adoptive cell therapy simply means you take blood from a patient, you isolate the immune cells, you re-engineer the immune cells and make them to have the ability to recognize and destroy tumor targets. Many will be familiar with what are called CAR T cells. Those cells are very potent. So from that same patient, now you can imagine you can manufacture billions of these cells and give them back to the patient almost like a blood transfusion. This type of therapy has been very effective for many liquid tumors, such as some leukemias, myelomas, and so on, but not so much for ovarian and many other solid tumors. So what is going on in the field now is to engineer what we call super CAR T cells or super immune cells that are engineered to be able to do many things and to be able to resist counterattack when they arrive within the tumor. So some of those are ongoing. There's one particular trial that was published in the past year looking at an antigen called MAGE-A4 in solid tumors, but there were a number of ovarian cancer patients in that trial that showed actually very spectacular responses to this type of therapy. So again, adoptive cell therapy is going to be one of those things in our armamentarium that we can really use to combat this disease and potentially improve the lifespan of patients with recurrent, especially in the recurrent setting, with recurrent ovarian cancers.
Thank you. And for everyone out there are many other immune therapies as well, trials ongoing using one called Artistry that uses nivoleukin. There's other trials, Preserve, using various combinations. So this is another approach, whether you're platinum resistant, platinum sensitive, HRP, HRD, all these other characteristics that you should just discuss with your provider. And as I say, online, OCRA has a great clinical trials finder site. Please use the resources of the Ovarian Cancer Research Alliance we're here for you. And I hope that these are some of the exciting directions you can have a further discussion with your own physician and provider. A lot of the questions had to do with PARP inhibitors and what's going on with the FDA, the current changes in it. And also, why don't we start there? And current use of PARP inhibitors. I know in my practice, patients who have a germline BRCA mutation, I am doing primary maintenance therapy with a PARP inhibitor, as well as if their tumor shows a somatic PARP mutation, BRCA mutation. When patients' tumors are homologous recombination proficient, I've no longer been using a PARP inhibitor, but perhaps, Premal, do you want to start with this one?
Sure. So I think it has also been a moving target, right? First, you can be offered a PARP inhibitor for all, as you mentioned, in the HR proficient. But the sort of benefit that we think we'll get for our patients is sort of marginal in comparison, right? Because it's about 3.8 months is what the progression-free survival benefit is. And these are oral drugs, but they do have side effects. As we all know, patients still feel tired or need to get weekly labs done, especially if it affects their platelets and it can get anemic. So I think, it's having that conversation with your patient, because I think still the one place we all agree that we need to get better treatments for is for our HR proficient patients. I almost feel like we have now these molecular signatures, and patients also have gotten a grasp of I'm BRCA positive, somatic or germline, or I'm HRD deficient. And then this little sunken feeling of I'm HRP.
So what do you do in that situation? There were a bunch of questions of
right. So I think they're great. So one, there's some clinical trials, so that's always a good option. But two is having that discussion, because it's individualizing it to the patient. I've definitely had, I'd say 50% of some patients who are like, yes, I want it, because with this FDA approvals going back and forth, this might be their only opportunity to see it, unless, in a later time they do go on a trial that might be in combination with things. I definitely would say a lot of patients are like, not for me, as well, but it's a nuanced conversation. I feel like where you really have to have buy-in from both parties to decide, because fortunately I would say the drug manufacturers have been still very generous of giving patient assistance, because these medications are quite costly for the co-pays for a lot of patients too. Because as we know, some of these patients unfortunately do fall into that. And luckily there are great organizations who can help, even foundations or charitable organizations. So I do think we have bevacizumab that we can also offer for patients. And there's definitely some of my patients who have started on bevacizumab with their chemotherapy who opt to stay on that. So there are options. But I do think that HR proficient is very sort of that still like
challenging
sides. Yeah. And then to the sort of, there has been this reversal of the FDA, right? That they have taken away sort of PARP usage in later lines, definitely third line and greater, for patients with germline mutations or somatic mutations, just based on data, which is a little perplexing to me that it was not the primary endpoint of those trials to look at overall survival. And they sort of looked at the endpoints and felt that the PARP inhibitor might be not doing as much of a benefit for patients. So that has led to the retractions of our PARP approvals, which definitely has caused some consternation among, I think, a lot of us experts as well, because we really want to use, as we're hearing, a lot of these tools at different points, and not everyone fits exactly every scenario. So we'd love to have that ability, I think, the art of medicine, right, to personalize to your patient as well.
Yeah, without overpromising and under-delivering either, which I think has been so much of the concern with everyone thinks it's going to be a magic bullet. Oh, I'm on a PARP inhibitor.
Right.
Andy, do you want to make a comment? Yes.
Yes. You mentioned at the beginning of this discussion of PARP inhibitors that you're giving them to all of your patients with somatic or germline BRCA mutations as first-line maintenance. And I think it's really clear that that's so important, because so much of what we do just sort of prolongs survival a bit and doesn't cure folks. Whereas, we now have 7-year follow-up on the SOLO-1 study showing about a 15 or 20% better survival 7 years out, after only having taken the PARP inhibitor for 2 years after the initial treatment. So I really am feeling more and more certain every day that we're actually curing more of those folks. So, that's kind of the brass ring or whatever that we've been sort of.
Yeah, no, I share your enthusiasm and also believe that many of those patients, at that 7-year point, have not had a recurrence. I'm not using PARP inhibitors. I do have a discussion, but I actually don't encourage PARP inhibitors in my HR proficient group because of the toxicities. And I think as I've seen patients on PARPs, every one of my patients, when they finish their 2 years or 3 years of their PARP, they all come back 2 months later and say, wow, I feel so much better now. You know, I think they're really nervous about going off the PARP because they've remained in remission and have found ways to accommodate their lives. But
well, yeah, I've had a lot of difficult discussions with people who don't want to come off.
Yeah.
Yes.
You know, because it's their security blanket and they feel like, oh, as soon as I stop this, I'm going to have a recurrence. But more recently, we've started to understand that prolonged use of the PARP inhibitors can increase the risk of AML, a form of leukemia that's not very treatable. So I think that, you know, it's been a caution flag to say, let's really prescribe these drugs in the way that they were used in the studies that led to the approval.
Prima nocere, we don't want to be causing secondary malignancies. I've had more than a handful of patients now have either MDS or, you know, full myelodysplastic syndrome or full blown leukemia. And as I've learned more about it, unfortunately, those leukemias are really tougher to treat. So while PARP inhibitors, I think, are now part of a standard of care for these subgroups of patients and have improved survival, maybe even affected cure, I think there have been really robust trials with good data to say one should not be on a PARP forever. They aren't gummy bears or multivitamins. And Kunle, what do you do with your HR proficient patients?
So the HR proficient population, I sometimes have to go through this difficult discussion about how I don't encourage PARP inhibitor use in that population for some of the reasons already stated. You know, the benefit is marginal, the side effects, but still, I think it's a physician-patient shared decision-making process where we evaluate the pros and cons of using PARP inhibitor. But my general thought is not to encourage it in that population. So this is the population where I think more about the use of bevacizumab for maintenance in that population, especially if they've been on bevacizumab as part of their frontline therapy or even as part of therapy for recurrent disease. So that is a population where I think it's reasonable to offer bevacizumab, especially patients who are tolerating it very well with no significant side effects.
Yeah.
Can I jump in on that? I'm sort of in the other camp where I'm not very enthusiastic about bevacizumab maintenance. You know, it is an IV therapy, so it requires trips to the treatment room every 3 weeks. It's not a pill like a PARP inhibitor. Yeah, there are potentially serious side effects. So our philosophy, making. Yeah, shared decision making, but our philosophy tends to sort of tilt more towards not giving it. And also the gain in PFS is minimal. And I think the longer term studies haven't shown any OS benefits. So
I think you're all hearing there are in the area where we don't have clear improvement in survival, like we see with PARPs in the HR proficient and HR deficient and the BRCA groups, there are different ways to skin the cat. Some patients say, you know, I don't want to have any maintenance if it's not going to be beneficial. Others want bevacizumab, others want a PARP inhibitor. And I think it is a place, there are many clinical trials in this area, please, that we all recognize this great unmet need, this great need that we need to find better ways for every woman who has ovarian cancer. Some of the other questions were PARP after PARP. So I'll go back and Andy, you know, I can let you lead off on this one. The patient who's maybe she's, you know, was on Solo 1, but she's now 6 years out. She completed her PARP 3-4 years ago, and now she's recurred again. Would you give her PARP again in maintenance after that recurrence?
Yeah, that's a tough one, isn't it? Certainly the FDA approval's not there, and guidelines talk about how there's no data on PARP after PARP, you know, using it again. So yeah, I mean, again, it's those individual discussions with patients, and some patients, when they hear there's no data, they say, well, there's no way I'm doing that. But then there's other patients who say, well, if there's a 1% chance it could help me, I'm definitely doing that. So you just have to navigate those individual sorts of interactions.
Yeah.
There is some emerging data. Okay.
Sorry.
You're talking about Oreo?
Yeah. The
Right,
Oreo
okay.
trial was there, which was olaparib after olaparib. But I think Dr. Karlan has a very it's hard because that wasn't those patients who had it 6 years earlier. So that might be a different patient population than Oreo, but the benefit was about 3.4 months or so. So it had a p-value of significance, but I don't think any of us who treat patients thought it was clinically significant. So it tells us also that trials can sometimes have a p-value, but what is really the clinical relevance? So I think that made me sort of feel like a PARP after PARP is not a great option. And they did have different PARPs. Not all of them had gotten olaparib first. Some had gotten niraparib or had been on trial, but I don't think they were exactly Dr. Karlan's patient. But so I think it is a discussion, but I agree with Dr. Berchuck that there are patients who are a 1% chance is a chance. So it is sort of that shared decision making. But I do think we have to learn more about PARP resistance too, because, Solo 1 has given us great sort of advancement, but I also made us realize that the biology of BRCA is so complicated too, because we always used to think those patients did so much better. And then we did see on Solo 1 that the ones who were not on the PARP sort of didn't do as well as we had all historically thought. So there's so much to understand about HRD and the pathways and the intersections that it's like platinum resistance. We're still learning, I think, a lot about that.
Yeah, and I think patients are individualizing, do they have a BRCA mutation? In considering PARP after PARP in the discussion, I think that is still a worthwhile discussion for individual patients and something that's should be out there for that discussion. Ways to overcome some of the combination therapies that Dr. Odunsi was discussing earlier are going to be really important. I hope everyone who's listening out there, this discussion we're having is women with ovarian cancer are living longer and they are able to lead full lives. And there are many, many options out there. As we were talking about the biology, we've changed the biology of ovarian cancer. As women live longer, we're seeing, oligometastatic disease, meaning one side of disease in a bone, in a lung, even brain mets. And we're still able to treat those women and have them live years afterwards, even after brain mets. So could you guys share your experience with things like, targeted radiation therapy, SBRT, IMRT for ovarian cancer as another modality, separate from systemic treatments?
So actually here at WashU, we did a trial looking at oligometastatic disease and the role of radiation. So we had, the trial was written up to 5 sites, but I'd say most of the patients had 3 sites of disease. And they're shorter courses of radiation. So they were nicer for patients as opposed to having to come, sequentially for 6 weeks, Monday through Friday. And we got really good control for patients, and the side effects were overall nominal. So it seems like it was able to be administered. It gave patients also a break from systemic chemotherapy or, different therapies so the side effect profile for them was beneficial to gain them time as a break sometimes from, systemic therapy, which I think is also alluding to the point that we're all saying we want to balance getting you great quality as well as getting this longevity too. So we were able to see an improvement with that.
I think nothing's off the table. I think these targeted ablative therapies.
And I definitely have used, radio frequency ablation for some of the endometrioid ovarian cancer that's gone to the liver and have patients who have survived years and has never come back. So I do think we can think outside the box. There's definitely gamma knife and radiosurgery that can be done for brain metastasis. We even have some radiopharmaceuticals for bone metastasis that, we can get from our colleagues for breast or lung who deal with this more often. So I do think, depending on where it comes, we can adjust to the tumor microenvironment, even though it's ovarian cancer that's led to this, to learn as well. So I completely agree. There's lots of different hats that we can choose.
No modalities off the table. Nothing's off the table.
So let me just quickly add, and I'll give one anecdote. So I think radiation we moved away from radiation several years ago in ovarian cancer, but I think it's an area that we have not studied as much. It's now very clear that one of the ways by which mechanisms by which radiation works is actually through the immune system.
Mhm.
Radiation is able to release, when it destroys tumors, it releases antigens that then are taken up by the immune system, again, to engender an anti-tumor immune response. I had one particular patient who was on a clinical trial of combination of immune checkpoint inhibitors and had stable disease, and then at one point had a lesion that was located in the area of the porta hepatis that and was causing some obstructive symptoms. We thought she was not a surgical candidate, but why not give targeted radiation to that area, which we did. Lo and behold, I mean, again, this is N of 1. I have not seen anything after that. N of 1, she was immune checkpoint and then required this targeted radiation. And she had incredible response, not just at that site, but across other sites, other multiple metastatic sites. So this is why I think this is an area that we need to study a little bit more and understand whether this, in fact, can be part of our regular thinking on how to treat patients with recurrent ovarian cancers.
I've actually seen an escopal response like that myself in a number of cases, and actually now have an animal model. We're studying it in Kunle. So I think that the idea of nothing being off the table and going back and saying what else might work. Clearly, radiation therapy can work for ovarian cancer. We had better systemic treatments for a while, so it went away. But I think our new advances that radiation therapy colleagues have has really allowed our patients to have better survival and treat those diseases that are outside of the abdomen now. I know we only have a few more minutes in this part of the session, but do you want to talk about some hormonal therapy approaches? We have combinations of tumors using aromatase inhibitors, CDK4/6 inhibitors. Any of you using those approaches or?
Yeah, more so in non-high grade serous types.
Okay.
The low grade serous granulosa cell tumors. Yeah, we've used letrozole, an anti-estrogen, and more recently CDK inhibitors, and have a paper in press showing some really nice responses in granulosa cell tumors, which are a rarer type. Unfortunately, the more frequent high grade serous don't often respond to hormonal therapies, but
we're actually seeing more responses by combining an aromatase inhibitor with a CDK4/6 inhibitor, and have had a clinical trial that's really looking very promising now using abemaciclib, one of the other CDK4/6 inhibitors. So I think just the point that each of you, as your tumor evolves, as Dr. Odunsi mentioned earlier, they do change over time using things like circulating tumor DNA, repeat biopsies, looking at new targets, looking at the clinical trials that are available. This is one of the most exciting times, I think, with each meeting. We come home with so much more enthusiasm that we are going to be being able to help our patients live longer, live better, and really, have a better life thanks to all the science and all the good care we partner with them. So I will thank my colleagues, Dr. Odunsi from the University of Chicago, Dr. Berchuck from Duke University, Dr. Thaker from WashU in St. Louis, and myself, Beth Karlan at UCLA. We're thrilled to be here with you, and we will have another session that will be available also to you in a little while. So thank you very much for your attention.